Good afternoon, everyone. This is the fourth lecture in congenital heart defects, and today's topic is around the Fallot um, congenital heart defect, and it's one of the very common scenarios that we encounter in radiology, cross-sectional imaging, whether CT or MRI. So the congenital anomaly is a conotruncal anomaly where the aorta overrides the right and the left ventricle. So the aorta, as if it's originating from both ventricles, but the overriding is not exceeding 50% of the interventricular septum, because if it exceeds 50%, this means it is in the spectrum of double outlet right ventricle, which is another entity. So the overriding of the aorta, so the aorta is overriding the interventricular septum less than 50%. This, of course, would explain why there is a subaortic or the membranous VSD, where there is a communication between the left ventricle and the right ventricle below the overriding aorta. And because of the overriding aorta, this is on the expense of the pulmonary area. So there is an infundibular stenosis in Fallot cases where the infundibulum is markedly hypertrophied. This marked hypertrophy will cause right ventricular outflow tract obstruction, and obstruction would lead to, of course, the fourth component, which is the hypertrophy of the right ventricle. So it's overriding aorta within a VSD, infundibular stenosis, outflow tract obstruction, and the right ventricular hypertrophy are the components of the Fallot tetralogy. And the treatment is to remove the stenosis of the right ventricle by the valvotomy, or whether the infundibulotomy, or the transannular patches and correction and reconstruction of the RVOT in order to relieve the obstruction of the right ventricle, because this severe obstruction and with crying sometimes would lead to that the shunt would be from the right to the left, and that's why they are cyanotic. If the pulmonary stenosis is not that severe, those patients are being called not blue Fallot but pink Fallot, where the shunt is very minimal, and that's why they are not cyanotic as much as where there is a severe stenosis. The overriding could be a very extreme, so that the pulmonary stenosis in extreme form, which might lead to pulmonary atresia, which is an extreme form of Fallot, but it's another entity to be discussed later on. If the patient has all those four components, and in addition there is an ASD, then it is Fallot pentology. And the management usually is around the first 2 years of life by relieving the obstruction in the outflow tract, by removing some of this muscle to relieve any obstruction. This in turn leads to another complication after the surgery, which is the commonest complication is the pulmonary regurgitation. And pulmonary regurgitation would lead to, of course, dilatation of the right side. Relief, yes, of the obstruction would lead to relief and decrease of the hypertrophy, but the pulmonary regurgitation would lead to dilatation of the right side. And decision when to correct this regurgitation depends on, of course, the clinical scenario of those patients. But usually the management tend to delay the intervention of the pulmonary as much as possible, as long as the right ventricle is stable, as long as the function is stable, as long as the volume is stable, in order to delay and postpone the intervention as much as possible, in order to decrease the number of future interventions. So it's important to comment on the amount of the pulmonary regurgitation, the right ventricular function, the right ventricular volume, and those parameters are correlating with, or they are one of the indicators when to change, or the PVR, would be indicated, or the correction of this pulmonary regurgitation is indicated. So far that the criteria is, the window is if the right ventricular volume hits the target, which is between the volume between 140 to 180. This is the window where it's an indicator to change the valve. And lately the literature has mentioned that even up to 200, because beyond 200 this means that this right ventricle is going to fail. So the window and will not improve, or the patient will not get much benefit of correcting the pulmonary regurgitation. So the window now is between the 140 indexed to 180 expanded to 200 milliliter per meter square. Right ventricular function, so if the right ventricular function falls beyond the 45%, or that the left ventricular function falls beyond the 50%, those are indicators that a PVR should be discussed in the MDT. Pulmonary regurgitation, if it's severe, so above 45%, or a free pulmonary regurgitation, is one of the indicators. So in the report, commenting on those parameters or the indicators of PVR is very crucial. In many scenarios, that those patients will come regularly for follow-ups to see any trend of dilatation of the right ventricle, or shutting down of the right ventricular systolic function, or increased amount of the pulmonary regurgitation. If the PVR is indicated, so there are two ways of correcting the pulmonary valve, either percutaneous solution or the surgical solution. Again, from cross-sectional imaging, we could help in the decision making, either through commenting on the size of the pulmonary valve area. So it's important in a 3D way, or a 3D measurements, to provide the measurements of the pulmonary valve area. So far, the Melody and the Sapien, the largest is the Sapien, and the largest diameter is 29. So if measuring the narrowest diameter in the pulmonary annulus, or the pulmonary valve level, or even in the supraannular, I mean the proximal pulmonary artery, if the diameter exceeds 29, then there is no implantation, percutaneous implantation solution for this patient. So it's important to comment accurately on the diameters. Now there is a new stent in the market called Venus, and I think it's larger than the Sapien. I'm not sure about the number. It might be 30 or 31 is the largest diameter for the Venus stent at the moment. But again, so far this is still not heavily discussed in the market. So the Sapien 29. The second point is, if you may see, sometimes we would be able to see the fat around the coronaries, and here's the left ascending, or the LAD is very, is it close or not close to the landing zone of the stent, in order not to crush the LAD between the stent in the pulmonary area and the aorta, or the left ventricle on the left side. So it's important to comment whether there is sufficient fat and sufficient distance between the LAD and the pulmonary. If you see that this is very close, so this is a red flag, the interventionist will test anyhow to see whether there is any compression to the LAD before putting the stent. But it's one of the flags that we could raise while reporting the Fallot cases post-operatively. Again, it's important to comment on, this is the patch where they closed, if you remember, so there was an overriding and there was a VSD. So now the VSD is corrected by closing the VSD by a patch. So it's important to mention whether there is any residual shunts through this patch or not, so that during surgery they might be able to check whether there is a residual shunt or not. Any other congenital anomalies also is very important to comment on. Sometimes during the MRI in the flow, if the pulmonary regurgitation is severe or there is a free regurgitation, sometimes it's not accurate measurements. So if you measure in one follow-up 50 and in the second follow-up 56 or 48, as a matter of fact, over the severe range, usually you will not be able to get accurate measurements. Again, for the percutaneous solution, it's important to comment whether there is any calcifications or not. Most of those patients are young, and in most of the cases, MRI 3D is sufficient to comment on the size and is sufficient to comment on the coronary relation to the pulmonary area. If within the institute the interventionists are not convinced, then you might consider, or you may consider, doing a CT for accurate measurements.